It's been just over 4 months since the first confirmed case of COVID-19 in Australia. In the months that have followed, we've all made sacrifices to halt the spread of the disease. Businesses have shut down, borders have closed, and loved ones have been isolated. Across the world, there's now a new understanding of exactly what it takes to contain a deadly pandemic. Tonight, we've assembled a panel of medical experts to help us take a look at what we've learned during the health crisis and the challenges that remain ahead. Also joining us for the discussion is Infectious Diseases Physician and Professor at the Australian National University Medical School, Peter Collingnon. Peter, welcome to the drum. Now, I want to start with this question because back in March, when so many aspects of this disease remained unknown, the government's own medical advisors warned that up to 150,000 people could die from coronavirus if strict measures were not taken. To date, that number has thankfully been far lower, but that's led to criticism from some quarters, quite loudly, in fact, over whether the lockdown was necessary given the damage done to the economy.
We have chosen to take the advice of epidemiological modelling, which was, as it turns out, ex post in hindsight, extremely overestimating the number of deaths that might happen due to coronavirus. And we've chosen to make economic policy on the basis of just those models.
Peter, did we move too quickly?
Well, I don't think we did move too quickly. Whether we were going to have 150,000 deaths or 10,000 deaths might be arguable, but we were going to have lots of deaths if we didn't stop this from spreading. You just have to look what's happened overseas to see how devastating it is. I think what was done in mid-March to late March was very important that we did in Australia because it stopped the spread. Now, whether we needed full lockdowns like New Zealand or which Victoria did might be a different argument because we managed to stop the spread without going that far. But there is no doubt we had to do serious things because even without the modelling, it was obvious what was happening in other countries already.
Right, so we just had to do with you're nodding there,
Yeah.
Darren, you agree?
Well, you've only got to look at what's happening in other countries. You know, the UK, the US, Brazil, Italy, other places that didn't really do what they were supposed to do and didn't do it fast enough. And you can see what the outcome of that is. And it's very easy.
Do you have any concerns about this modelling?
No, I don't. I mean, you've got to look back and think at the start of March when we did this, we knew a lot less about this disease. There have been thousands of scientific papers out in that time. We knew a lot less about it. All models have uncertainty built into them. They're not perfect predictors. They work better in different areas.
So we have to err on the side of caution.
Absolutely, absolutely. And I think, you know, it's really easy to sit here now and go, gee, we overreacted. And even before anything happened, people were saying, if this works, we're going to look back and say, gee, we overreacted. And I think that was quite prescient.
But what do you think, Vyom? We haven't heard the end of this discussion, right? It's going to go on, and discussions that aren't led by health experts can often take a different bent. We are going to be asking about the economic cost. We are going to look back at that initial modelling because we'll have to come up with further modelling potentially in the future should this arise again. How do you view the decisions that we took based on the information that we had at the time?
Well, the way I look at it is the unique, I don't want to say unique Australian approach, but certainly a lot of other countries have followed the hard and fast approach that Australia's had compared to a lot of other places. Like, who else would we rather be? What were the other countries with their set of assumptions that they made about projections of deaths, etc.? Do we wish we had followed the epidemiological modelling of Sweden, for instance? And I think looking back, you have to be pretty pleased with our progress. I think exactly like Darren said, we're in public health, when you're trying to prevent a crisis, it looks like an overreaction if you did everything right. And the main thing I think we've done with our early response is prevent a worst of all worlds scenario, where not only do you end up with an economic crisis, but also potentially a health crisis as well. And when you look at countries which have had a far more kind of laissez-faire approach, that's the situation they're finding themselves in. So it's not like if you did everything right in the economic short term, or what it appears to be, that you don't incur any of the economic harms. We're seeing similar downturns in the economy of Sweden as compared to its neighbours, except they've got worse health outcomes.
Yes, and we're coming to Sweden shortly. There's something I want to ask you, Peter, about this modelling, which is there seems to be epidemiologists and health experts quoted today saying the modelling is not overestimating the risk, it was underestimating our ability to respond to it and to change our behaviour accordingly. Can you explain to me where this assumption comes from in terms of our behaviour, that we weren't going to adapt, that we weren't going to be careful? And why did we buck that?
Well, I think that's one of the problems with some of the modelling and something called the R0. It assumes that you do not do anything to change your behaviour and therefore the reproduction number goes unchanged. The reality is if you see images of people dying and you know something's going bad, both the government and individuals are going to act and they're going to do things to stop it spreading to them. So I think that's one of the problems with the models. If the models assume that nothing will change, that's not a good number to do your basis of predictions on. And also the mortality number is a bit harder to figure out because early on it always looks worse than what it is. But I might say with this one it's still pretty bad because it's still around at least 1%. I think one of the things about, though, learning from other countries is, yes, I don't actually think we should go the way of Sweden, but Korea was about a month ahead of us and did very well at controlling it without a total lockdown, and the same in Taiwan. So how far you go with the data you have is another question. I think we've had quite a good response in Australia without the total lockdown, for instance, that New Zealand did, without objective evidence that we're worse off for doing that.
Right, and we are going to come to Taiwan in a moment as well. Vanessa, can I ask your opinion? From what you were saying earlier, you seem to believe that we should have done even more with the lockdowns. We should have been more cautious than we were.
Yeah, I think we should have. When we just hearing what was said then about the reproduction number, because people don't realise that that reproduction number, say you have 2.6, which is that somebody will infect 2.6 people in, say, 3 days, 3 to 6 days. And then those 2 to 6 people will infect another 2.6 people in another 3 to 6 days. So you go from 6 people in 3 to 6 days to 12 people in 12 days. And if somebody is asymptomatic, then the virus is spreading a lot quicker. And when we looked at what Korea had done, and they got in early, they did their contact tracing, they did a multi-pronged approach, and we could have been quicker, and we could have prevented a lot of losses of unemployment, I think, had we taken strategies from those other countries and taken it on board and taken the necessary steps to actually take that multi-pronged approach of health promotion in with an epidemiological approach.
Look, we've heard Sweden mentioned by the panel. They've taken a very different approach to us here in Australia, and there's no lockdown put in place at all. Businesses have remained open and the country's leaders are playing a long game, banking on the population developing immunity. To date, there have been over 34,000 cases and more than 4,000 deaths. That's nearly twice the death rate of the US. And the economy is still suffering in line with much of Europe. Sofia Lindstrom, an intensive care nurse in Sweden, has told The Drum her government's policy still remains broadly popular.
Right now, we're only treating COVID-19 patients. The mood has been good, even though we're tired and maybe a bit frustrated. We have been supporting each other. People dying when I've done my best, that's not the hardest part. It's when people are not getting the care that I know I could give. Of course, it's very hard to predict what the outcome may be, but I think we're still in the middle of this and we can't yet decide what's right or wrong. I think maybe in a couple of years' time, we'll see what was the best strategy. I think everyone in the society are feeling safe with the restrictions that we have. Everyone is responsible. I feel proud. And I don't know if that's right or wrong. I'd say time will tell, but I'm proud that we have the guts to try something else.
Oh, it's such a fascinating response to this, Peter. But we've had a lot of talk about herd immunity, people concerned about it being followed in Australia in the early days. There's discussion of it in the UK. What do we know now about herd immunity as it relates to the coronavirus and whether it can be effective?
Well, basically, I think the cost of herd immunity is probably too high. If you look at Sweden, with 50 times the death rate of Australia, probably, that we would have had 5,000 to 10,000 deaths by now if we'd followed that approach. But still not probably achieving herd immunity. Even in Stockholm, the figures I've seen, no more than 15% of people maybe have had, evidence of infection and therefore presumably some immunity. And all the current theories about herd immunity is you need 60% or more. So I don't actually know, for all their deaths and suffering, that they're not going to get, be in the same position in, 6 months' time. Now, there's a lot we don't know, but I think currently the Australian approach, where we've had less than 10% of all our cases of community spread, has been very good from what we did from mid-March to late March. People can argue we should have done more, but I think we've got one of the best results in the world without totally crippling the economy as well.
Darren, you are nodding firmly. I know you want to speak about the Sweden thing as well, but I also want to ask you, because I know you've come on the drum repeatedly during this time, and every time you're like, the studies are coming in so quickly and we're trying to stay on top of it and we're trying to get across the nuance. Right. Yeah. What do you feel we know now? And if we're not 100% certain of, we're more certain of than we were when this outbreak occurred?
I think we know a little bit more about the way the disease behaves. I think we have a better understanding that the disease behaves differently in different places. Even within Australia, it's behaving differently in different places. I think the thing that I took from that Sweden vignette, which is really interesting, is that one of the things that models find very difficult to do, whether it's economic or epidemiological, is to build in human behaviour into the models. And we know from data in Australia that people are broadly very supportive of what the government's done. And there's also data, ABC's own data from surveys shows that even if they took all the restrictions away right now, a lot of people would still modify their behaviour in line with the restrictions that were there.
Yeah, Vanessa, does this surprise you because this is what was modelers underestimated, the rate to which we would comply and be cautious and care about it?
It does surprise me in the sense that because I catch a lot of public transport and I don't see people complying at all. I don't see people doing the physical distancing. I don't see people wearing a mask. I don't see people washing their hands at the train station or anything. So, so it does surprise me that they're complying. And I also did not see any of the police in the areas where there were high levels of COVID virus. I saw the police in areas where there was high populations of Aboriginal and Torres Strait Islander people. So, to me, there were so many mixed messages in that whole approach, and what we need to make sure is that we have this multi-pronged approach, because when the COVID app was introduced into the country, they were told, the government made the clear message that if you want to go to the football, get the app. And people got the app and forgot to, to take on the multi-pronged approach. I was on the train and I sneezed in my mask, and the woman in front of me, 2 seats in front of me, she gets her phone out and looks at her contact tracing app.
Yeah, right.
Yeah, and I was just like, what?
Right.
And I get allergies, so...
Well, maybe she's just trying to get more information. It's hard to know. But speaking of multi-pronged approach, this is why we need to talk about Singapore now, because early in the outbreak, Singapore was singled out for its ability to contain the virus, and things got really quickly under control. But after early successes, a second wave broke out amongst vulnerable migrant communities and led to an additional lockdown. There are now more than 32,000 cases, but only 23 deaths. Professor Dale Fisher, the Chair of Infection Control at Singapore's National University Hospital, has been working with the Singaporean government during the crisis. He updated us on the current situation there.
Our numbers were going up in those early days from single digits up to 70 cases a day, which meant that we really had to bring in the social restrictions. And this was happening when everything was in good shape. We had good testing very early. We isolated all our cases. We had good contact tracing systems, and still we couldn't control it. And that's my biggest lesson, is this is incredibly slippery and it's very easy for it to get away from you. The dormitories are clearly a different situation and a different outbreak altogether. There's been a large number, obviously, get infected, and that's reflected in our numbers, which are over 30,000 now. Total, I think, of around 500 in the rest of the community. So it's a very, very asymmetric epidemiology gone on. Singapore is lifting its restrictions very slowly because it does take a while for that change to be recognised in the community.
Now, Vyom, I want to talk to you about Kerala in India now, because one very distinct point of contrast to what happened to migrant workers in Singapore, where people were housed in close together and it spread quickly and it was hard to break up. They handled that in an entirely different way in Kerala, didn't they? And it was very effective at stamping it out. Can you explain to us what happened?
That's right. So whereas the rest of India has really been struggling with migrant workers and they've just been scurrying off to all their respective states and told to go, Kerala firstly recognised the situation extremely early and at one point was quarantining. We're talking people in the hundreds of thousands. There's obviously a lack of sanitation in India as a known problem, but they were given makeshift toilets and meals, 3 meals a day for up to 2 or 3 weeks. And there was a broad recognition that we're really going to have to care for people, and not just the people who fall within the visions of governments typically, but the people who are in the blind spots. And India, as there was in Singapore, it's the migrant worker population. And as a result, this state with a population of 30 million people has had 4 or 5 deaths from COVID-19 and just a few hundred cases. And this is not exactly a particularly resource-rich part of the world, somewhere like Kerala, but it just shows that you have quite a holistic approach that just focuses on the simple things and yet applying them to everyone and not letting certain parts of the population fall into your blind spot. You can have great results.
And having had years of investment in public health systems, especially in recent years, which the health minister seems to have said has paid off now, especially when it comes to respiratory diseases. Now, Peter, when you look at Singapore, do you worry about complacency and do you worry about that here?
Well, yes, we do have to worry about complacency. Perversely, we've done so good. Everybody might say, hey, what's the problem? We don't have to do all the things that we know stop the spread. And basically that's hand hygiene and keeping physical distancing from other people and avoiding crowds and not going to work when you're sick, etc. But I might say Singapore is a good example of what you need to do to stop this from spreading. The real problem is they've got a lot of young migrant workers with maybe 20 people in a dormitory where it's very difficult to keep physical distancing. So it's not a great surprise then you get ongoing replication. So you really do have to do this for everybody that's in your remit. You can't have one set of rules for people that are wealthy and then another set of rules for people who are poorer.
Right.
You've got to have the same rules, the physical distancing for everybody and the hand hygiene.
Right, and the rules like in Kerala, for example, if you were isolating at home and you didn't have a toilet in your house, you couldn't stay in that house. You had to go to government accommodation, and so they kind of ensured that there was that distancing happening, even amongst kind of the poorer neighbourhoods. Now let's talk about America now, because today the US officially passed 100,000 deaths from coronavirus. The newspaper USA Today has marked the grim milestone with this front page, honouring those who have died from the disease. The United States has recorded both the highest number of cases at more than 1.6 million, as well as the highest deaths. Dr. Jennifer Pinto-Martin, a professor of epidemiology at the University of Pennsylvania, told us how the fight against the virus has become politicised.
In the US, we don't have a federally mandated, coordinated strategy. So the states are left to come up with their own plan, both in terms of testing and in terms of reopening. President Trump put out a plan for reopening that had a gatekeeping mechanism. You can't reopen unless you've had cases going down consistently over a 2-week period, which I thought was a reasonable gate. And yet, because we don't have adequate testing and because there's no way to control what a governor decides, that hasn't been adhered to. So I think it's really unfortunate that it's been politicized, because this virus knows no political boundaries, right? It's going to affect everybody equally. And I think what it's causing is behavior that is putting the population at risk in general. I think it's being fueled by our own president, which is also unfortunate. And he has a mind of his own and acts of his own accord, and I think has created some very deep and long-lasting problems as a result.
Vyom, we've had American doctors come onto this show and say they can't believe that they go home from their shifts at night working in ICU and hop online to Facebook, trying to correct misinformation, trying to stamp out the politicisation of it, which can have destructive impacts. How do you think you best counter something becoming political, where you have one side of politics wearing a mask and another side refusing to?
Yeah, and so this is a difficult battle that even we're starting to fight a little bit here. I think it's specifically for medical professionals when we're speaking about COVID-19, it's so important that we at least begin with the facts and the figures as they stand, and then talk about the range of options that are available and talk specifically about the data and the evidence. Now, it just so happens with COVID-19, even the discussion of the evidence, specifically some drugs being touted by President Trump, are also becoming incredibly politicized. But this is a very difficult exercise, and I find it getting more and more difficult, especially with the influence of social media. You get particularly misinformed people who've been hit by 4, 5, 6 pieces of propaganda on blogs and Facebook videos, etc. And people come with these quite firm understandings and stances about about how to best tackle COVID-19, informed by their ideology. It's a really tough problem. But what I find best is just to stick to the facts and back everything up with data.
Now, Darren, as someone who's interested in the communication of science, you've concentrated for a long time on how to stamp out myths. You do a lot of work on Twitter, trying to counter it all the time. Now, of course, you've made it to the drum debunker, so congratulations. But what have you observed about misinformation during this virus that's particular or heightened, and how to best counter it?
So the one thing I have observed is that hyperpolarisation along political lines, and we're bashing against the US presidential election, and that's clearly playing into that. How you counter that, I honestly don't know, and it really saddens me to watch play out. I really don't know. I don't think anybody really knows how to counter that. In terms of the broader picture around misinformation, there's an awful lot of work going on around this. And one thing we do know, and Vyom, it's really important that we do get the evidence and fill the space with fact. But the one thing we do know is that facts very, very rarely change somebody's mind about something. What you have to try and do is align those facts with people's belief systems. That's the really important thing.
How do you do that
That's
if you're
really
suspicious about vaccinations, or you're suspicious of the government?
Yep. It's really hard. You have to listen for a start, treat it as a conversation. But I think what's really important and what's really becoming clear from some really interesting informational epidemiological evidence that's coming out is that the patterns of the way the information is spreading through the community, both online and offline, show us some of the ways forward in how to stop this out. And there are information super spreaders, just like there are viral super spreaders. Right. We need to shut those down really early. We need to make sure that people have access to the right information when they need it. Because,
I mean, you can tell us about the cost this is having on people's lives. Like people thinking, it's just a flu, therefore not going to hospital. They're drinking bleach, they're injecting themselves with various things, all kinds of crazy
This
stuff.
has real cost. I mean, some of the conspiracies I've been reading today, or some of the misinformation I've been reading, is that the virus is a hoax, but it's also spread by 5G. It's also there to spread nanobots and just to make everybody have a vaccine. But pharma companies are covering it up to make money. So it's kind of like Schrodinger's virus. It kind of exists and it doesn't exist all at the same time. How do you counter that? I don't know how you counter
It's something we're going to keep talking about on the show for sure. Well, I want to talk about Taiwan now before we go, because the island is no stranger to viral outbreaks, and that's perhaps why it's been seen as such a successful case. There have been just 441 cases to date and only 7 deaths. Dr. Chuan Chen is the Dean of the College of Public Health at Taiwan National University. He says the 2002 SARS outbreak in China provided some valuable lessons.
We are happy of what we are doing so far, but we are still very cautious. We act decisively at a very early stage. First of all, is we imposed the border control. The SARS outbreaks 2003 hit Taiwan hard, and we learned the lesson. From that time, we know we never can expect timely and correct information related to newly emergent diseases from China. The other thing is, after the SARS, the whole society has been preparing for the next pandemic, because it's really heartbroken to see doctors and nurses die in hospital. Many countries have the first lessons this time of COVID-19. They should take this kind of lessons we had before and start building the infrastructures that very important to be ready for the next wave.
Now, we're almost out of time here, Peter, but really interesting response, because in Taiwan, a combination of a suspicion of information that's going to be given to them about this spread and the nature of the virus with intense preparation. What do you think the lessons are? What can we take from Taiwan?
Well, I think there's a lot to learn from them. Mind you, I think Australia has learned a lot of those lessons. In the public health laboratories around Australia, we very quickly got tests up and running from scratch with it because there were no commercial kits, because we were expecting it to arrive in Australia. And that proved to be very useful for Australia to have lots of testing very early. We also did close our borders relatively early compared to the rest of the world. Maybe we could have done it a bit earlier, but I think a lot of those lessons that Taiwan put in place we have done in Australia as well. And particularly if you take into account only 10% of our cases, or about 700 were true community spread, we've done pretty well because most of the cases have been returned travellers or people from cruise ships, which we need to take. So I actually think there's more we need to learn, but we've not done too bad so far in Australia.
And meanwhile, we've got about 20 seconds left, Darren. We're all waiting for a vaccine.
Vaccine, I mean, that will be a game changer if and when it happens. That remains to be seen whether it will. I hope it will. It looks promising.
The question is how much money we spend on it, as other countries are doing, in terms of taking that risk, and we haven't.
I think we're taking a right approach there. I actually support that. You know, the vaccine will come from the hundreds of candidates that are out there in development. I think to back one now is a dangerous thing.
Okay, we're going to end on that note. That is all we have time for tonight on The Drum. I want to thank our panel who've talked us through all those complex issues, Darren Saunders, Vanessa Lee, Vyom, Sharma, and to our guest, Peter Collingnon.